here at all, then I would have had a tissue problem. That's why I said my second site is going to be on the palate. Because if I put it here, I'm going to be fighting the tissue. She's going to be uncomfortable. So I'm going to put it in the palate. So the reason why, and Russell actually, who's 70-something years old, he's actually done some micros. And I don't know, I'm pretty sure he put them in too. He went and did a course and did it. But the reality of it is, yes, I put them in. And after you do the first couple, you realize it's no big deal. And after somebody's had one on, they realize it's no big deal. And I've got on my iPhone, I haven't reloaded, actually maybe one here, but I can show you there's one on here of one of my staff where, put one in on her. I've offered my brother to let him put one in on me if he just wanted to do it. I mean, there's a video on YouTube where he's a dual trained orthodontist oral surgeon, and he puts one in on himself. On the video, and it's basically so he can show his patient, hey, it's no big deal. Look, I put one in on myself. But that's the thing is, it really, it seems scary, and it seems like I do a ton of these. But the reality of it is, I'm just showing you, when we treat a good many patients, and I don't use anything a lot. Most of them I don't. It's just a very small percentage. But that was a horrible game. Oh, anybody go to that game? Oh yeah, horrible game. Cuspid impactions. Basically, take home point on this is we take a look here. I'm following this tooth that's starting to overlap here. We took out the baby teeth. Hopefully this will redirect it to come back. Guess what? Doesn't happen. They're getting worse. These are overlapping. They're going in the palate. They're going mesomigrant. Well, look, these are too. Great. Wow. They're not going where they're supposed to. That's going to be a problem. Maximum Eicher's case, we look at him and go, okay, he's a deep bite. He's got crowding. His bite's already off. This tooth is more forward where it's supposed to be. It's supposed to be back here. We need some maximum anchorage. So basically, with him, I put an anchor up there. Put the anchor in. Put this appliance on top of it. Put some plastic to attach the two together. And basically, I've been using it to just back everything up. Yes, ma'am.
Do you make all your own, you could call them like appliances? Do you make
Yes, we make them all. We have a lab for that stuff. Because I can tell you, we made that up. a lot of orthodontics is problem solving. That's what I said. I look at it and go, ooh, here's how I'm going to do it. And we need to make this. So a lot of it, that's half the fun of it, is coming up with stuff. But the reality of it is that we still got a long ways to go. And if you look here, on this x-ray, you can see these cuspids have chains on them, and we're pulling them back, and that's the bump right there. That's the bump right there. There's always distortion on x-ray, so what it looks like on the x-ray versus where it actually is different. But we've almost got enough room here. We'll get this tooth in, and we're going to use some springs to shift this bite. Sometimes we have to punt. This is a transfer case. She was being treated by another orthodontist, and had braces on for 5 years, and these lower incisors weren't straight. You can see here on the x-ray, there's some brackets still on there. And the orthodontist was having a difficult time getting those lower incisors straight. Well, there's no, if they would have been straight, they would have been out in front of these top teeth. If you take a look on this x-ray, you're going to see these teeth are flared forward. Okay? There's a certain inclination where we want the teeth to be, but they're too far forward. And long story short, she's missing them over here. So if I take out teeth, I got to take out teeth in all 4 quadrants. Guess what? Sacrifice it again. Now she does have a wisdom tooth up there. Okay, you can't count on wisdom teeth. They're not always what you need, what you want. They don't always come in the right way. Sometimes they're not formed properly. But she does have a wisdom tooth, so that's a backup plan. I take out this tooth, I close space. Then the wisdom tooth's going to be way back there. Then down the road, she's going to have another set of orthodontics to bring that tooth forward. So we looked at it and said, you know what? What if I take out teeth on the lower? Take out bicuspids on the lower, take out a tooth on this top side, and then here, we'll have an oral surgeon put a plate up there. And I'll distalize everything. We'll take that wisdom tooth out and I'll move everything back on this side. So we won't have to take anything out. And I won't have to worry about, in the future, this wisdom tooth that maybe is not in the right spot. So that's what we're going to do. We're going to take out teeth, and that's her, pressing those lower incisors way out there. She's got pretty full lips. Basically, you take a look at her midline. Her upper midline is to the right side of her face, and then that's where she kind of was in treatment. But We were, during the course of treatment, the midline pretty much got on the face, and we had that plate on that upper right side. And where the oral surgeon put it, I was having tissue irritations. I mean, the poor girl, the gum kept growing over it, and I had this thing coming out, and it was a nightmare. Every time we have to go and activate it and mess with it, and she was in pain, it, had to, remove some tissue over top of it, and I was like, it's just isn't good. We got to the point where I just said, hey, the space was closed, the space over on this side is pretty much closed. We got a teeny bit of space left here. I still got a ton of space on the bottom to close. On the top, we didn't take anything out, but this space is closed here. Her midlines are on their face. I'm like, okay, let's do something different, because I don't want to close the space here. I've got to keep retracting. Okay, these front teeth are coming back, these back teeth are coming forward. But if I keep retracting here, I've got to keep retracting on the top. Her midline's going to move in that direction. She's had a lot of pain, soft tissue. I told the oral surgeon just take the plate out, and I went back and put an anchor here and decided to bring it forward. Now, so I had to change plans. And closing space here, I didn't want these front teeth to move around because my midlines are on in the front. And so although I took out the same teeth on both sides and things were, seemed like they would move symmetrically, well, they didn't. Bodies doesn't always act the way you want it to. So I used an anchor here to drag these forward. So I closed the space by bringing this molar forward. And ultimately, that's what the anchor looks like, and this big pokey wire right here. Certainly you don't want anybody leaving your office with the wire sticking up like that. But here's where she ended up. So, profile-wise, things line up pretty good. Space is closed. Midlines are on their face. Midlines are on with each other. It's pretty much what we're shooting for. You don't need to take it down. Any questions? That's another experience. That's it?
Wow.
Yes, sir.
Where did you go to school?
I went to Francis Marion.
And did you go anywhere afterwards to do orthodontics, or is that?
No, I just taught myself. Yeah, I went to dental school at MUSC. I graduated in '96, and then I did my residency in Kansas City, Missouri. At the time, they didn't have a residency in South Carolina, so you had to go out of state somewhere. And I applied to, I want to say 10 programs. Got 6 interviews. Got into those. I'd have gone anyway. It's pretty competitive. I was telling somebody there were 200 applicants for 4 slots, and you don't have to be all that smart being orthodontist, but they can be choosy because they've got enough people who want to do it. So, most of you, my guess is most of y'all want to be physicians. There's only a few that you want to do dental dentistry, but the reality of it is, in anything, you need to keep your options open. I mean, I talked to a few of you, and you said, well, I'm not sure what I want to do. When some people were saying surgeons and that sort of thing. But the reality of it is that you got to keep your options open. You've got to, pad your resume as much. You got to keep your grades up. You got to do all the stuff that you got to do because you want to be able to really choose at the end. Yes, ma'am.
So when you were at dental school, did you know the whole time you wanted to be in orthodontics, or did that just at the end you were
when I was at dental school, yes. When I went to, at the time I never had orthodontics. So I alluded to what I was doing before. I used to show horses, and I was going to do that professionally. And I came to my senses and said, okay, I don't want to live on the road the rest of my life. There's a term, horse trader. You can't trust people in the horse business. So that's that's just not what I want to do for a living. So I used to show a horse for a guy that was an orthodontist, and I really didn't know anything about dentistry at the time. I'd had my teeth cleaned, had some fillings, but he had a good quality of life. He showed up, was a good guy, I was happy. Seemed, hey, I want to do what he does. My brother at the time was ahead of me, and he had already decided he wanted to do orthodontics, and he kind of paved the way. I mean, it was like, if he can do it, I can do it. Half of doing anything is believing you can do it.